Hello, and welcome to Nephrology Nursing Perspectives, an official podcast of the American Nephrology Nurses Association. This podcast provides interviews and discussions between members of the American Nephrology Nurses Association and the nephrology community. The podcast focuses on nephrology nurses' issues, health policy, and nephrology nursing as a specialty nursing profession in the areas of conservative management, peritoneal dialysis, hemodialysis, continuous kidney replacement therapies, acute kidney injury, transplantation, industry, and health policy. In this episode, Ms. Lillian Pryor, the 2020-2021 president of the American Nephrology Nurses Association, talks with Dr. Deidra Cruz, a professor of medicine in the Division of Nephrology at the Johns Hopkins University School of Medicine in Baltimore, Maryland. In addition to having received numerous awards, including the 2018 Johns Hopkins University President's Frontier Award, Dr. Cruz holds appointments with the School of Nursing, the Welch Center for Prevention, Epidemiology, and Clinical Research, the Center on Aging and Health, the American Society of Nephrology, where she serves as secretary, and the Center for Health Equity, where she is deputy director. In her conversation with Ms. Pryor, Dr. Cruz discusses how nephrology nurses can advance equity in kidney disease outcomes by focusing on social drivers of health inequities. We are pleased to present Ms. Pryor's interview with Dr. Cruz.
Hello, everyone. My name is Lillian Pryor, and I am here on the Nephrology Nursing Perspectives podcast with Dr. Deidra Cruz. We are very, very excited to hear from Dr. Cruz today. And just to give a little bit of background, Dr. Cruz is a professor of medicine in the Division of Nephrology at Johns Hopkins University. And what she's going to speak with us about, we're going to have a little conversation about social determinants of health. We're going to talk a little bit about social drivers in health equities. But we're going to focus, of course, on kidney disease because that's kind of what we do and what we want to know about and how we can help to move those drivers or to fix those drivers. So I now introduce to you Dr. Deidra Cruz. Hey, Dr. Cruz, how you doing today?
Hello, I'm doing really well. Ms. Pryor, Lillian, it's so good to see you.
Thank you so much for being here. And I'm going to jump right in because I am very cognizant of your time. And I know for a long while you have done research on social drivers. Specifically, we're looking at kidney disease and how that kind of affects kidney disease. And I'm going to let you just tell me a little bit about the background of your research, maybe how that became a thing with you, how you got interested in that topic and where it's taken you.
Yeah, well, first of all, thanks for having me. Really looking forward to chatting with you today. So in terms of my background, so I'm a nephrologist, as you mentioned, a very proud nephrologist. And when I was being trained as a nephrologist, I also got training at our School of Public Health at Johns Hopkins in epidemiology. Mm-hmm. And so I started off when I first sort of started doing research, looking at kidney disease. I was really focused on trying to understand which populations, particularly in the United States, have greater risk of developing CKD or chronic kidney disease. And I'll say that for a whole host of reasons, I was particularly interested in understanding disparities in kidney disease, both as a Black American myself and also someone who comes from a family that's been significantly affected by kidney disease. I was very interested in trying to understand why we see the disproportionate rates of kidney disease among Black individuals in particular. So that was sort of the beginnings of some of the work that I was doing. And so when I was doing some of my early work, one of the things that we found in a Baltimore-based study was that we found this relationship between living in poverty and having a greater chance of having chronic kidney disease. And it seemed like living in poverty had an even greater effect for Black people than it did for white people. Mm-hmm. And this was in a Baltimore-based study. And I started to become very interested in, what is it about being Black and being poor in this country that might raise a person's chances of developing kidney disease and started to then look at this similar questions in larger studies that had more people that had been followed for longer to sort of allow us to look at a number of different factors. And one of the things that through that work that myself and my colleagues landed on was that one issue was surrounding access to what I often refer to as sort of health promoting goods and services, with one of those being access to healthy food. And so a lot of my work has focused on, particularly in recent years, has focused on trying to understand that social driver of kidney disease being food, healthy food access. And through working with colleagues and some of my research mentees have expanded that to look at other social drivers like housing, access to sort of affordable housing and stable housing, and the role that also plays when it comes to kidney disease. So that's some of the early beginnings, but that's how I sort of landed on trying to dive deeper into this question.
Okay. And you talk about quite a few things that are, I think, front and center, particularly now. Since COVID, I think a lot of things have had a light shone a little brighter on them. And you mentioned the social determinants or the social drivers. And I think for a long time, we've always known, or for myself, I want to say we've always focused on the tertiary part of the problem, which is your disease process, but we don't focus much on the stuff that comes before that. Mm-hmm. And these are the social drivers, I think, that you're alluding to, your access, preventative stuff, the stuff that's going to prevent the disease from happening. So just now, let's dive a little bit into your research. And we talk about those social drivers, and specifically for kidney disease. I think I heard on a webinar, you talk about food. Food is actually medicine, right? So let's talk a little bit about that. And I know that's kind of at the heart of where a lot of your research lies.
Yeah, so definitely this work that we've been able to do around food, I think is definitely something I'm pretty passionate about. And so I think some important things to sort of keep in mind, like when we look across the country and we see that there are communities where maybe people don't have as many full service supermarkets where they can access fresh fruits and vegetables, or they have income levels that make it difficult for them to purchase healthy foods. There's been studies showing that it is more expensive to purchase healthy, fresh, like fruits and vegetables, for example, in particularly most communities, around the country than it is to purchase things that are less healthy, junk foods, as these are often colloquially called, right? And so when we looked at that question, we know from other work that the patterning of the sort of healthier foods around this country, and particularly in a number of sort of cities and areas around the country, we know that there tends to be greater access to those healthy foods in communities where either the income level is quite high of the residents, or where the majority of the residents are white individuals, as compared to communities where there are a lot of people of color living in them. And we know that that's not by accident, and it's really by design. And so practices dating back more than 100 years ago now of restricting where certain groups of individuals could actually set up businesses and get loans to sort of build homes and other sort of places. We know that practices such as redlining, which was that practice by which banks would restrict these loans, we know that they disproportionately affected a number of communities of color, particularly Black individuals, as well as religious minorities as well in that practice. In Baltimore, for example, the practice of redlining was kind of levied against both Black people as well as Jewish individuals as well. And so all of that sort of frames this backdrop. I think a lot of times we tend to look at the present state of, maybe the Black patient in front of us doesn't seem to be following the dietary recommendations that we're giving them, without taking into consideration the context that they're living in, and also all of the historical factors, historical and present day, factors that play into the context that person's living in. And so with that as a backdrop, a lot of the work we've been doing is, one, to try to characterize, what it means to be living in these sort of environments, and what it means for people, how they view that experience. We've done some work even in training such individuals in how to photograph their food environment, and have been able to present those findings in some different forums. And then we've recently finished up a clinical trial that's actually trying to address this issue of healthy food access among Black Americans with both hypertension and early kidney disease. So you touched a bit on this idea of prevention. Now, for sure, nutrition is an important issue for people across the full continuum of chronic kidney disease, whether it's people who have risk factors like diabetes and hypertension, but haven't yet developed kidney disease, all the way up through people who may be treated with dialysis or treated with a transplant, for that matter. Nutrition has been important for all of them. I would say I get most energized around thinking about how to address these issues earlier on so that we can hopefully prevent people from maybe even from developing kidney disease in the first place, but also prevent those who have early disease from seeing that disease progress to kidney failure. And so that's kind of been the focus of a recent clinical trial that we finished up, where we worked with a local grocer to provide fruits and vegetables to participants. And then and then we coach the participants on how to sort of incorporate these healthy foods into their diet. And we're in the process of kind of analyzing our findings at this point to see if that actually helped to reduce the amount of protein they were losing in their urine, their albuminuria, and also to improve their blood pressure. So those are some of the things that we've been attempting to do really to address this issue.
Okay. And that kind of leads me into, I guess, my next question, or my next topic that I wanted to just talk a little bit with you about in terms of nursing. Now, our Future of Nursing 2020-2030 is actually entitled Charting a Path to Achieve Health Equity. And so just what you're talking about, it talks about the upstream part of health equity. And some of that alludes to some of the policies and the practices that you've talked about that have been in place forever, right? For as long as I can remember. But also we want to talk about that access and the collaboration. So the collaboration piece that you talk about is, I think, key in these communities. And how were you able to just kind of collaborate? Who did you collaborate with to kind of, get this project going with the healthy foods?
Yeah. So I've benefited from having that study nested within our Center for Health Equity at Johns Hopkins, which its founder and director, Dr. Lisa Cooper, and other colleagues at the center have, through the years, developed relationships with a number of community partners who have been stakeholders in all of our research projects that have come out of the center, the study included. And then we were able to actually build further that community advisory board that we have for the center to include additional people who have lived experience with kidney disease, or work with organizations that are supporting people with kidney disease, to include them early on in the process. So when we were just designing the study, we had these individuals included, right? So that we could get their views on how best to shape the intervention, how best to determine kind of what the control group should get. That was a pretty robust discussion we had early on, and ultimately agreed that they advised us that as investigators that the control group should get something pretty good, right? That they shouldn't just get nothing, right? So so the control group actually got a gift card to the same grocer that the intervention group received grocery delivery from. And so things like that, we've learned a lot. And but those partnerships are best developed ahead of when these sort of different studies or programs are launched, so that they can be informed by those groups that really do have a stake in what the outcome is going to be. And also, it really does help then at the end of a study to then be able to disseminate. They're going to be the ones that are going to be able to help disseminate the findings, right? They're going to be highly motivated to really help get the word out about these types of findings or different programs, if they have been involved in the whole sort of process of it. And so the goal is always this co-ownership of these different studies. And so that's something that we definitely seek to achieve at our center. So that's how we were able to do that. And it's been a really enriching experience for me. I've certainly learned a lot from the process.
Oh, great. And that's a very important point. Even as nurses, we have that opportunity to involve those stakeholders. We have the families of the patients that we care for, and so we are able, and we have a captive audience, basically, right? So we can invite them to actually participate and help us to make things better. That's beautiful. And it's certainly important to make sure that they feel like they are part of the process from the very beginning. There's nothing worse than telling somebody, oh, by the way, this is what we're going to do. Can you do this? It never works, right? Or it never works well. Never works well. All right. Well, thank you so much. I have one last question, and this is just kind of a throwback. So I was doing a little research myself, and I came across what's called the Theckler Report. Now, the Theckler Report was written in 1985. The woman who did the report was named Theckler. The report was named after her. And she was asked because they noticed some of the disparities in healthcare between, minority populations and white. And so she did some work. And I'm just going to read a few of the things that the report showed. And I just want to get your take on that. So some of the suggestions for improving healthcare services and programs for minorities included continued support for the existing health programs, minority-specific research data collection, prevention and health education programs that incorporate bilingual services, right? Because we also have our Latinx and even our Asian communities, minority participation in policy development, education and training programs, and improved access to healthcare through modification of third-party payer systems. And just a few of the most critical disparities they identified was, like you said, access to healthcare, chronic diseases, pregnancy and birth disorders, availability of data. So we're in 2022. Doesn't that sound to you like right where we are? And this was, well, maybe we've progressed a little bit, but what are your thoughts on that from, 35 years ago, right?
Yeah, the Theckler Report. So about 2 decades after that was Unequal Treatment, which was a report out of the now National Academy of Medicine, the then Institute of Medicine, really, again, both documenting disparities and also calling for other sort of steps that needed to be made. And I think the Theckler Report for sure had some foundational recommendations. The idea of just even tracking these disparities was somewhat new in some ways, because there had not been a substantial amount of tracking of these sorts of things, really, especially across levels of government where government programming was kind of at play. And so progress is slow, I think is what all of that says. And from my standpoint, what it really does require is political will, in addition to sort of individual efforts and political will at the level of our leaders, as well as that the collective requests of the populace, right? For those of us who are voters, to really demand these sorts of things. But, I don't look at this as, even though the progress has been slow, I still see that there has been progress. Yes. And I still, remain hopeful that particularly over this past couple of years in the setting of the pandemic, as well as high profile acts of racism that all of us have seen videos of, that I remain hopeful that there's energy to, continue to move forward, to try to advance this work and try to address disparities. In my moments of concern, I do still get concerned that the political will is not always there, as well as one of the concerns that I have is that in history, what tends to happen after progress around these issues is there tends to be backlash around many of them. And so we're already seeing some of that, some of the laws that are popping up in various states that really are discriminatory in many ways, laws around what can be taught in schools. I mean, all of these different things play a role in our ability to sort of advance justice at large, and including justice surrounding health. And so that does give me some concern, but I'm still hopeful that we are going to continue to move forward and address these disparities.
I am too. I'm glad you added that political piece to it, because sometimes as nurses, we kind of step back a little bit and we're a little reticent, I think, of getting involved in that. And that's really almost foundational to the advocacy that we should be doing. And so I know, just even based on the Future of Nursing 2020, 2030 and ANNA, the organizations were just kind of, and ASN, just rallying together to push and to really get into those, because that's kind of what's going to drive a lot of the lessening of the disparities and move us forward to health equity. So, all right. Well, I want to thank you so much for taking a few minutes of your busy schedule to speak with me today. And before you go, I'm going to thank you in advance. You are speaking for us at the ANNA National Symposium in May. Can you give us a little teaser about what that talk is going to be like?
Well, I'm super excited to join you. This will be my first time attending the ANNA conference, and I get a good amount of time there to talk more about this issue of diet and disparities surrounding diet and the way that they are at play when it comes to kidney disease. And so, I hope to see you there, as well as, others that may be tuned in and listening to our chat today. So looking forward to it.
Great. Well, thank you so much. And we are going to wrap this up, and we look forward to another Nephrology Nursing Perspectives podcast soon. I hope you all enjoyed this, and take care. Bye-bye.
Nephrology Nursing Perspectives is owned and produced by the American Nephrology Nurses Association. All rights reserved. No portion of this podcast may be used without written permission. Dr. Deidra C is a professor of medicine in the Division of Nephrology at the Johns Hopkins University School of Medicine in Baltimore, Maryland, and she holds appointments with the School of Nursing, the Welch Center for Prevention, Epidemiology, and Clinical Research, the Center on Aging and Health, and the Center for Health Equity, where she is deputy director. Her research focuses on addressing disparities in the care and outcomes of kidney disease and hypertension through epidemiologic studies and clinical trials. An elected member of the American Society for Clinical Investigation, Dr. C has received numerous awards for her research contributions, including the 2018 Johns Hopkins University President's Frontier Award, the 2019 W. Lester Henry Award for Diversity and Access to Care from the American College of Physicians, and the 2019 Distinguished Leader Award from the American Society of Nephrology, where she currently serves as secretary. Ms. Lillian Pryor is Senior Manager for Medical Education for CVS Kidney Care. A member of the American Nephrology Nurses Association since 1990, Ms. Pryor has served in roles that include President-elect, ANNA Director, ANNA Awards and Scholarships Committee Chairperson, ANNA Representative to the Kidney Health Initiative Patient Preference Task Force, and an author and peer reviewer for the Nephrology Nursing Journal. Ms. Pryor served as the 2020-2021 President of the American Nephrology Nurses Association. In addition, she is an active member of ANNA's Dogwood chapter in Georgia and has served the chapter as both its president and health policy representative. For archived episodes of this and all ANNA podcasts, and to learn more about the American Nephrology Nurses Association, visit annanurse.org. You can subscribe to Nephrology Nursing Perspectives, NNJ Extra, and ANNA's 50th Anniversary podcast series on Apple Podcasts, Google Podcasts, Spotify, Stitcher, TuneIn Radio, our hosting site Spreaker, and everywhere podcasts are found.